Friends, thank you for coming for this competition, 3-minute thesis. Before we, just to introduce, it's people presenting their research ideas shortly, briefly, but at the same time as communicatively as possible. How they can tell their story in 3 minutes, what did they do for their research, either MD, MS or their PhD work in 3 minutes with a single slide. I'll introduce the topic a little further, but we thank you, Pastor, for coming. So we'll begin our competition with a word of prayer.
Let's bow our heads in prayer. Lord, we thank you for this wonderful morning. Thank you for this new day. We come before Thee and worship You this morning. As Your word says, the fear of the Lord is the beginning of wisdom. Help us that we may continue to fear You and honor You in everything that we do, particularly this morning. As we go through this 3-minute presentation, we pray for all the participants. Grant them Your confidence, Your strength, and Your presence. Pray for the judges. May You grant them Your prudence. Pray for all of us and organizers. We pray, Lord, that we may understand many things that You have in store for us. The knowledge, the understanding, the wisdom from above may be imparted to us for Thy glory and for Thy honor. In Jesus' name we pray. Amen.
Good morning. First, I'd like to welcome all the participants. Thank you for agreeing to take part. Some voluntarily, some forcibly voluntarily took part. The competition is called 3-minute thesis competition. The participant has 3 minutes to present his thesis or her thesis. They have only one slide, that's the rule. That one slide should not have any animation, no transitions, no music. The time starts from the time they start speaking, and the time stops when 3 minutes is over. If they exceed 3 minutes, they'll be given negative marks, so 3 minutes is 3 minutes. That's a simple competition. We have 18 competitors today, so the slides have already been on, so the names will come on. Between competitors, there is 30 seconds for the judges to judge, and we won't have questions during the time. When the competition finishes, if you want, you can ask some questions to the competitors. But very quickly after the competition finishes, we'll have the marks tallied, and we'll have the winners announced. I'm very grateful to our CEU Director, Dr. Abraham Pidikel. Thank you, sir, he's the inspiration for us. He is one of our judges. The second judge is Dr. J.V. Peter, our Associate Director and Head of Medical ICU. Then we have Dr. Anthony Sami, Professor and Head of Biostatistics. He's been a mentor for all of us and also a part of our CEU. So I'm very thankful to the 3 judges. Thank you very much, sir, for being a judging panel. I want to thank Dr. Vishali. She is also one of our stalwarts in CEU. She's helping us with the marks and also with any helping in the process. So I want to thank Dr. Joy Michael, our Vice Principal, for coming. In the interest of time, we won't have any speeches. We'll start off straight away. And our first competitor, Dr. Veera, from biochemistry. He has 30 seconds to come and introduce himself and his guide. And then when the clock starts there at 3 minutes, his 3 minutes will start. When his 3 minutes finishes, the next competitor will start. So, Dr. Veera, you're on.
Good morning all. I'm Dr. Veera Manikandan from the Department of Biochemistry. I did my thesis under the guidance of Professor Molly Jacob. So regarding the background, clozapine is an antipsychotic drug used in the treatment of a group of schizophrenia patients who are actually resistant to the first generation antipsychotics. And this is because clozapine is associated with various adverse effects and variable clinical outcome. And the reasons for these variations in the treatment response could be many, out of which the genetic factors is one important thing. Here we try to look into a polymorphism located in the promoter region of DR4 gene that codes for dopamine dopamine receptor type 4, and clozapine binds with this receptor with very high affinity, and so it made sense to look into this polymorphism in this context. And the methods, we recruited 95 patients from the Department of Psychiatry. We included only those patients who had a diagnosis of treatment resistant to the first generation antipsychotics and those who were on clozapine for at least 12 weeks. We excluded patients who refused for the consent and those who had severe neurological impairment and sensory impairment. And we collected the socio-demographic variables, and the clinical assessments were done by the psychiatrist, and I did the genotyping and the statistical analysis. Regarding the genotyping, I did with the conventional PCR followed by an agarose gel electrophoresis. Regarding the results, so first we categorized the patients according to the BPRS scale, which denotes the psychopathology of the patient. So we had a cutoff to categorize them into responders and non-responders. As you can see from the pie chart at the other end, there is no difference in the frequency distribution of responders and non-responders between the three groups, which says that there is no significant association. In fact, this finding was reinforced when we analyzed the BPRS scale as a continuous parameter, where you can see the median lines of the three notched box plots at the same level, indicating that there is no difference indeed. And we analyzed for the association with lot of adverse effects. Interestingly, we saw a distinct pattern with hypersalivation, which is one of the common adverse effect of clozapine. As you can see, the red dots, which indicates the presence of hypersalivation, is dense in the heterozygous and the homozygous group than the wild type, which says that the having a mutation duplicated allele actually increases the risk. And even more interesting is that it followed an additive model of inheritance. That is because the patient who are homozygous for the polymorphism have double the risk of patients who are heterozygous for the polymorphism. And this data can be potentially useful for the treating psychiatrists to screen the patients to identify who will get the adverse effects, so that precautionary measures can be taken. And I'd like to thank the financing bodies, my co-authors, the patients, and last but not the least, my guide, Dr. Molly Jacob. Thank you.
Good morning. I'm Dr. Deepthi Bal from Department of Medicine. I did my thesis under the guidance of Dr. Tambu David. If anyone in this distinguished audience considers themselves immune to hypertension, think again. In a previous study done in staff student health services, 1/4 of our staff are already hypertensive who are 45 years and older. Having experienced firsthand the stressful, rather unpredictable lifestyle of a doctor working here, it made us wonder, and therefore we decided to do a questionnaire-based case control study to determine the risk factors for development of hypertension while working here. This is what we found. Sadly, family inheritance does not always gives its rich dividends. For those of you who have family history of hypertension or diabetes, you are 17 times more likely to develop hypertension in comparison to your colleagues otherwise. You are what you eat. Next time when you indulge into the savory delights of Shanti Bakery, I caution you, dyslipidemia and diabetes makes you 3 to 5 times more likely to develop hypertension. Life is more interesting with a little bit of more seasoning, but your food is better off without that additional pinch of salt. Fruits, however, is greatly welcome. Another risk factor which came as significant was reduced milk intake in our diet. We in CMC take great pride in our long, arduous working hours. In spite of it, did you know that 36% of your colleagues have promoted themselves from normal BMI to being overweight or obese since their employment, thus making themselves 3 times more likely to develop hypertension? Also, about half of the employees were already pre-hypertensive at the time of their employment. Also, stress at work and at home emerged as a risk factor in our univariate analysis. Modern elevator is a faster stairway but to heaven. Next time when you avoid it, do remember that the odds for you to develop hypertension is reduced by 5 times if we just physically exercise while at work. On multivariate analysis, the boxes marked in yellow are the independent risk factors. Finally, as Renault neighbor sought wisdom to know the difference between the things we can and cannot change. As a physician, I strongly believe that when it comes to risk factors for hypertension, there is a lot that can be changed than it may seem. Thank you.
Morning. I'm Ajoy. I'm from the Department of Medicine. I did my thesis with Dr. O.C. Abraham, and we studied clinical outcomes among hospital-acquired infections, patients in ICU. Morning, everyone. I'd like to start off by asking you a question and then telling you a story. So the question, if you were to have a fever, would you rather have the fever before you reach the hospital or after? Now my story. So Mr. Chinnappa presented to our hospital with fever and breathing difficulty. And by the time he reached us, he was breathless, he was sweating, and our team of doctors found him with hardly a pulse palpable. And so we rushed him into the ICU. We put him on a ventilator. We put him on a list of medication to increase his cardiac perfusion, and we put him on the best antibiotics available. And slowly but surely, Mr. Chinnappa improved. His fever came down. His breathing difficulty became better. We were able to reduce the ventilator all the way down. And then, tragedy struck. Again, he had new onset fevers in the hospital. His ventilator settings went all the way back up again. Slowly, he had renal shutdown, and eventually he passed away. So here's my question. Who done it? Who killed Mr. Chinnappa? Or what killed Mr. Chinnappa? Now that's the question that my thesis aimed to answer. And 130 patients, and 1.5 years later, we had one primary suspect, Acinetobacter, responsible for 61% of all our hospital-acquired infections, 70% of those being ventilator-associated pneumonias. So obviously these patients had poorer ventilatory outcomes. That is, half these patients either died or remained on a ventilator for more than a month. But did Acinetobacter actually kill these patients? Now, there's the catch. You see, when we looked at the patients who developed Acinetobacter infections, we found that they were already very sick to begin with. Acinetobacter did not cause any additional mortality more than we would have expected for their disease. Now, why is this important? Why would anyone spend and treat Acinetobacter infections with all these high-grade antibiotics, with all their costs and all their side effects, if it's not going to change their outcome anyway? Well, that's the question. So, going back to the important one. Did Acinetobacter actually kill these patients? Maybe Acinetobacter was just a spectator who was watching a tragedy show unfold. Or maybe Acinetobacter was the final breeze that pushed these really sick patients over the edge of the cliff. Maybe Acinetobacter was the final nail in the coffin. What's the answer? Ask me in a few years, I'll tell you. Thank you.
Good morning to all. First, let us understand the background and the significance of the thesis topic. I did my thesis on prevalence of anemia in pregnant mothers under Dr. Rubijo's guidance. The thesis topic was detection of anemia in pregnant mothers to correct and prevent complications during childbirth. As you see on the right side of the slide, I put the Millennium Development Goals, which are set by the United Nations Development Program. According to that, goal number 5 is to improve the maternal health. Maternal health had some indicators for us, the maternal mortality ratio and the proportion of births conducted by the trained health personnel. And they are given set targets for that. That is, there should be reduction of maternal mortality ratio at least by 75% when you compare 1990 to 2015. So the set maternal mortality ratio by 2015 is 109. And also to achieve universal access to the reproductive health by 2015. When we looked into the causes for the maternal mortality, we realized that 35% of the deaths were caused directly by hemorrhage. So the importance of anemia is highlighted. So we decided to do a study of prevalence of anemia in pregnant mothers who attended our outpatient departments. So we taken 600 pregnant women and we did an observational study with the aim to detect the prevalence of anemia and to correlate its risk factors with its occurrence and to give recommendations for the prevention. At the end of the study, we realized that the result is prevalence is only 23.16%. And we also realized that the severe anemia is present in only 0.17% of women. So with most of our women entering pregnancy with either normal or mild to moderate disease, then why do they have this increased mortality? Then we looked into the other factors and we concluded that it's not only important to have good hemoglobin levels during pregnancy, it's also very, very important to have prevention of acute blood loss during delivery and also to have postpartum anemia prevention. So, at the end of the study, we gave recommendation that each and every pregnant woman should have adequate antenatal visits so that the anemia is detected and it's prevented, and also they come to labor with good hemoglobin levels, and the delivery is conducted by trained health personnel so that the acute blood loss is prevented, and also when they come for postnatal checkup, they should have good hemoglobin levels, preferably more than 10 grams percentage set by the World Health Organization. So to substantiate our recommendations, we are following this same population group into the next pregnancy, and we are checking the postpartum hemoglobin levels also. Thank you.
Good morning, everybody. Prior to the 1800s, a patient who presented, a patient who had hollow viscous perforation with peritonitis or who had intestinal obstruction, more often than not, would have very high mortality rate. The few patients who actually survived were those in whom the intestinal contents were able to find its way out of the body and form an enterocutaneous fistula. This was keenly observed by the surgical fraternity, and by the 1850s, the construction of planned fistulas or stomas were rampant worldwide. So by the 1850s, a stoma was being done for patients who had intestinal obstruction or perforation to divert intestinal contents. A colostomy is nothing but an operation that's done to divert fecal matter, and a loop colostomy is when a loop of intestine is brought out to the skin, and thereby it helps in fecal diversion. The most dreaded complication of a colostomy is the fear that this loop of intestine which has been brought out will go back into the abdominal cavity. And therefore, most of our ancestors in the surgical fraternity felt that you needed to have a sort of a rod between the skin and the loop of intestine to prevent this stoma from going back inside the abdomen, and which can lead to fecal peritonitis. This, however, has not been studied in any great detail, and this has been given as a norm, and almost all surgical textbooks, right from the most basic to the most comprehensive surgical textbook, will always recommend that you place a stoma rod to prevent retraction of a stoma. We, however, felt differently, and therefore we decided to enroll our little stoma rod and set it through the rigors of a randomized control trial. And interestingly, we found that the main reason why a stoma rod is placed historically was to prevent retraction. And in our study, which is which almost enrolled close to 100 patients, we found that this was not true, and there was no difference in retraction rates between the two arms. And even clinically, we didn't feel any difference at all. What was even more surprising was that the post-operative complications, which the rod is supposed to prevent, actually is enhanced in the group which had rod. And so the stoma rod, which was used to prevent complications, actually had a significant number of complications in the arm in which the rod was placed. And more than 25% of these patients had to have the rod removed by the surgeons because they felt that it was detrimental and not helping the patient at all. So this is probably the first randomized control trial that we've come across internationally, and this has definitely changed practice, at least in our unit, and we hope to take this forward by publishing it so that obviously more studies will be needed to corroborate this, but this is definitely, at least in our hospital, the standard of care has changed and we no longer use stoma rods.
Morning. I'm Dr. Vijay from General Surgery. I did my thesis in soft tissue infections with Dr. Deepak Abraham from Endocrine Surgery. Actually, when you look at when you go to any emergency day, you'll see at least 8 to 9 soft tissue infections in one day in an emergency department. And as you go across, and you'll see most of the patients come very sick, and most of the patients has been treated in another centers, come very sick and ends up in a high morbidity. So we started looking into this, and we found that over the last 3 millennium, right from the times of Hippocrates, Hippocrates, and even older than that, there is evidence of soft tissue infections existing in this world. But 3 millennia, we have not done anything because the morbidity was bad then, the morbidity is bad still now. So it's around 60% of morbidity and around 30% of mortality. With the last 100 years of advances in medicine, all we have done is to have high-end antibiotics for high-resistant bugs. But only in the last 100 years we have known one single fact. lots and lots of studies that has been done which shows that any delay in diagnosing a necrotizing soft tissue infection leads to a delay in the surgical treatment, which is the treatment of soft tissue infections, and hence the mortality and morbidity. There are various people who have done various studies to see how things have been done, whether there is any way to predict necrotizing soft tissue infections. All of the studies, and I repeat, all of the studies done in the past, almost around, there are 83 studies which shows that all the studies are retrospective studies with its own biases. So we have come up with our own prospective study. We thought we'll include all the factors, historical factors and examination findings and the lab parameters to see if there is any factors that we are picking up, and we did a nested case control study. So I recruit these patients, and at the end of discharge, the patient will either be falling into a morbidity arm or a non-morbidity arm. So once I reached 55 in each arm, that my sample size was 110. So I recruited actually 123 patients to reach this because there were lots of non-necrotizing infections. So at the end of the study, we have recruited the patients. At the end of discharge, they either fall into the NSTA arm or non-necrotizing arm with morbidity or mortality. And after statistical analysis, this is what we found. The factors that predicts morbidity are high elevated neutrophils, or low sodium and fever, diabetes, ventilation and dialysis. With this in background in mind, what we are trying to achieve is that we are trying to formulate a score, and with that score, we are trying to see if we can predict a necrotizing soft tissue infection with an objective manner. If this objective manner comes into standard, and we are trying to validate with a score, with a study, and if it gets validated, then we can say this scoring system will be the objective standard in diagnosing non-necrotizing soft tissue infection, which in turn can lead to emergency debridement surgical treatment, which definitely leads to decreased mortality and morbidity.
Good morning. My name is Lahun, and I did my MD PMR from the Department of Physical Medicine under the guidance of Dr. Raji Thomas. My two biggest passions are medicine and music, and it was on combining these two passions that I began to learn about the science of music and rhythm. And my thesis explores into the possibility of using music as a rehabilitation aid in our patients. Sound travels through a pathway in the brain which begins at the cochlear nucleus, which is present in the medulla, and this travels on to the Heschel's gyrus present in the lateral sulcus of the brain, specifically in the right hemisphere of the brain. It is this area which understands rhythm and pitch. And how we can then follow rhythm is because of a principle of physics which is called the theory of entrainment, where two molecules which vibrate against each other then transfer sound, and that then translates into rhythmic movement. So using the aesthetic concept or the old concept, music was used as a rehabilitation aid in critical patients in the ICUs or in the wards, found good outcomes. Rhythmic auditory stimulation, a subclassification of music, was also studied for gait rehabilitation in stroke, cerebral palsy, in Parkinson's disease, multiple sclerosis, also found very good outcomes. But no studies were reported regarding rhythmic auditory stimulation on gait training in amputee patients. So we attempted prosthetic gait training in 29 unilateral transtibial amputee patients. Recorded beats were given using MP3 players, and these which were attached to earphones. And these beats were varied according to the frequencies of the abilities of the patients to walk. There were two groups. One was the RAS group, which was the experimental group. They were given beats, and the other one was the control group, which received conventional therapy. They were not given beats. And these, after the end of the entire training, they were then deemed independent only after achieving certain set tasks. So one of our primary outcome measures was the time to complete training. What we found was that the patients in the RAS group actually finished faster than the patients in the control group, and also 50% of the outcome measures were favorable towards the RAS group, but significant p-values could not be achieved. I strongly believe that rhythmic auditory stimulation can show significant benefit, especially in our group of patients, but maybe larger studies and long-term follow-ups will be needed to support this hypothesis. And now at the end of my thesis, I am just as excited as I was when I first began it, and I hope I will be able to continue in this work. Thank you.
So time for some basic science. I'm Dr. Anand from the Department of Biochemistry. I'm working as an assistant professor here. I did my MD from PGI Chandigarh under Dr. K.D. Gill. So aluminum phosphide, or in short ALP, is a pesticide and one of the most common causes of poisoning due to suicidal intent. The poisoning is associated with high mortality, about 30 to 50%. So after it's taken orally, it gets broken down to release a highly toxic gas, phosphine. Now, how exactly phosphine acts is not clearly understood. However, some studies indicate that it acts at the level of mitochondria. So mitochondria, as you might be aware, are cellular organelles producing 90% of the cell's ATP requirements. So the the foodstuffs which we consume are broken down to release energy, and this release energy is channeled as electrons. These electrons are shuttled across several carriers present in the mitochondria, and this is indirectly coupled to ATP generation. Now, for any reason, if this process is inhibited, it would lead to rapid cell death. Now, phosphine, the effect of phosphine on mitochondria has been earlier studied in insects and in vivo conditions. Whether this happens in vitro is not clearly known, and in vivo is not clearly known, and that was the primary objective of my study. So we recruited 21 patients of aluminum phosphide poisoning, and we studied the activities of 3 complexes, complex 1, 2, and 4. These are complexes involved in the mitochondrial electron transport, and we studied this activity in the platelets of the patients, and this was compared against healthy controls, as well as a group of shock patients, and found that the activities of all 3 complexes were significantly inhibited. So we extended the study to animals, and we found similar results in them, that rats treated with ALP had significantly lesser activities of these enzymes. We were also able to visually see the mitochondria by electron microscopy. The red arrow would show swollen dysmorphic mitochondria, again indicating that there is evidence of mitochondrial injury. Now the question comes, is phosphine just associated with these findings, or is there a chemical plausibility? When we looked into phosphine's chemistry, we found that phosphine is actually a very strong nucleophile, that is, it's electron rich. So due to this property, it can actually donate electrons to these electron acceptors in the mitochondria and thereby inhibit it. In an independent study, we were able to measure some of these cytochromes and found they were inhibited. The clinical implications would be to know whether assessing these enzyme activities could help in diagnosis or prognosis of the patients. This would need future studies. And from a basic science perspective, it would be worthwhile to test mitochondrial protection strategies in ALP poisoning. I'd like to acknowledge the help and guidance of my my supervisors. The data represented here are published, and the journal information is given below. Thank you.
Yeah, good morning. I'm Angel, and my thesis about one of the emerging greatest threat to the mankind. And my guide is Dr. Priscilla Rupali, professor and head of infectious diseases. Okay, when I said one of the greatest threat to human mankind, yes, we're talking about one of the diseases, obviously, and that is malaria. So if you see the first picture was, what did we see? So this is what we saw, that malaria is a disease of the tropical countries, causing great morbidity and mortality. And of course, 92% of cases from Southeast Asia, 50% is contributed by India. And the earliest signs of emergence of resistance to antimalarials, to the latest first-line antimalarials, which is the artemisinin combination therapy, was first demonstrated in the Cambodia-Thailand border. That is that small village we see there, and it was actually a great threat. And so what did we do about it? We wanted to see if the resistance has crossed the borders and is reached our place. So we did a prospective cohort. We enrolled 54 slide confirmed cases of falciparum malaria, and we studied the parasite clearance time and the fever clearance time. Parasite clearance time we defined as the time taken after giving the antimalarial therapy for the first negative blood smear free of parasites. And fever clearance time is the time taken for the fever to reach below 37 and to remain there for 24 hours. And we defined resistance as per WHO guidelines to say if there is presence of more than 10% of patients in that area with Day 3 parasitemia, that is after 48 hours if you detect parasites in your blood smear. And we also went ahead and looked at the drug levels in patients who responded to therapy and who did not respond to therapy. And what did we find? Yes, we're finding that the resistance is crossing the borders. The treatment failure rate, what we found in our cohort, was 25.5%, which is well above the WHO threshold of 10%. And we correlated all the possible host factors and the drug levels, and we found that they did not contribute to treatment failure. probably indicating that it's a resistant strain of the parasite. Yes, and we also found some more interesting things, that the drug levels are lower in our cohort compared to all the other cohorts in Vietnam, Cambodia and Thailand, indicating there must be something to do with the dosing strategy among the North population. So what are we planning to do? We have saved our samples from all these patients, and we are planning to go ahead and confirm the emergence of artemisinin resistance by studying the mutations which are known to be associated with artemisinin resistance, called as SKELCH13, and that is the way ahead to prove that this is the greatest threat to mankind, of course, and in India. Thank you.
Good morning. I am Sindhu. I've done my MD in community medicine here, and I'm currently working in the Wellcome Trust Research Lab. My thesis was done under the guidance of Dr. Kurian George and under the co-guidance of Dr. Paul Russell from Child and Adolescent Psychiatry. You would be definitely not be surprised if I put forth the fact that we in India, we stand in the #1 position with respect to the number of preterm borns every year. Well, it's a whopping number of 35 lakh preterm born children we deliver every year. Who is a preterm born baby? A preterm born baby is one who is born even before the mother completes 37 weeks of gestation. Now, the short-term plethora, immediate aftermath effects of preterm born children have been well taken care of by the advanced modern technology. But what about the long-term sequelae? A topic, an arena much untouched, especially in a developing country like India. So the main aim of a study was to detect the effect of preterm birth on intellectual ability. Now, is it a reality that we haven't as yet really realized? Okay, so we decided to do this study in the Kanyambari block of Vellore, which is catered to for its health needs by the Department of Community Health and its secondary care hospital, which also houses in a very robust health information system. And it is through this health information system I access the birth cohort of the preterm born children and their term counterparts born between the years of 2001 to 2005. I went on to look on at these children in the year 2014 who were currently aged between the years of 9 to 11 years. So finally the study design I deduced was a retrospective cohort or a non-concurrent cohort study. Now, when I looked at these children, I used a very simple tool called the BITS, which is called as a Brief Intellectual Disability Scale. A very simple tool, doesn't need too much training. 30 minutes of training of even a paramedical worker or social worker is sufficient. This scale has just 10 simple questions, and it has 3 important options which are scored on the basis of an agree or a disagree scale. A maximum score obtained by a child is 20. But well, if the child has a score of more than 11, it means the child is definitely intellectually disabled. If the child has a score of more than 5, it means that I am suspicious of the child having an intellectual disability. This tool was designed, evaluated, and validated by the Department of Child and Adolescent Psychiatry. So when I looked at these children, I took 202 preterm born children and 204 term born children. Interesting results, 5.4% of the preterm born children were intellectually disabled compared to just 0.5% of the term born children. They had a 7 times higher risk of developing intellectual disability, who may further referred for management. So I would like to say that this is a very simple screening tool. And why do we need to do this? We need to do it at a much earlier stage when the child has actually made a career choice, avoiding undue stress on his family, himself, as well as a society. Thank you.
I'm Karthik from Department of General Medicine. I did my thesis under the guidance of Dr. K.V. Peter. Scrub typhus is an acute febrile illness which is caused by Orientia Sutsugamushi, which is caused due to the bite of this trombiculate mite. And from a previous study, we have seen that scrub typhus can result in up to 20% mortality due to multi-organ dysfunction. But what are the cardiac manifestation? Nobody has known so far. So we did my thesis on cardiac manifestation scrub typhus infection. So what did we do? This was a prospective cohort study where we screened patients with scrub typhus infection for cardiac manifestations. So what did we do? We screened patients with help of echocardiogram, with electrocardiogram and cardiac enzymes. Echocardiogram was done by myself and trained critical care sonologists. And to reduce inter-observer variability, we did a validation study where 20 patients were screened individually by both the trained critical care sonologist and myself. And validation was done using kappa and correlation coefficient, and which revealed substantial agreement. Then we also looked at the cardiac manifestation in terms of ECG findings. So what did we find? We looked at myocarditis, which is defined as you all can see from the Venn diagram, it's a combination of myocardial dysfunction plus myocardial injury. So myocardial injury we defined as patients having elevation in troponin T levels due to myocardial injury, where the myocyte is injured. And myocardial dysfunction was evidenced by left ventricular systolic dysfunction, as evidenced by as what we saw from the echocardiogram. A patient with we defined patient with myocarditis, someone who had a combination of both myocardial injury and myocardial dysfunction, which is about 21%. And patients with myocardial injury was about 62%, and patient with myocardial dysfunction was about 30%. So from our study, it has been shown that myocarditis can be seen in about 21% of the patients. And from this study, we know that almost 60% of patients with scalp typhus have myocardial damage. So, which results in prolonged ventilation and prolonged ICU stay, and the need for ventilation also increase in these patients. So we would like to know what is the pathogenesis causing the myocarditis. So in future, we would like to do to look at the autopsy studies to look at what is the pathogenesis for myocarditis, which will help in treating these patients better for improved outcomes. Thank you.
Good morning, I'm Niti Matthews. I did my MD in pathology here in CMC, and I did my thesis under the guidance of Professor Anna Pulimud, and my co-guide was Dr. Rekha Pai. My thesis topic is characterization of microsatellite instability in young patients with mucinous colorectal cancers. There was a time not very long ago when having a cancer was equated to having a death sentence. But not anymore, thanks to the in-depth knowledge of the molecular basis of cancer development and progression, which translates into better therapeutics. However, there are small patient subsets that tend to be unique, as suggested by the data published by the colorectal surgery unit here in CMC, which revealed an alarming finding. Almost 36% of rectal cancer patients who came to us were 40 years or younger in age, and this figure was much higher than the international average. Since MSI, or microsatellite instability, has been shown to be a good predictive and prognostic marker, we decided to characterize this subset based on their MSI status. Now, microsatellites are tandem repeats of 1 to 6 nucleotides on DNA, which are maintained in a constant length by certain proteins called mismatch repair, or MMR proteins. Now, these proteins act as spell checkers on DNA, and when they are altered or absent, it leads to MSI, which aids the development of cancer. Now, studies worldwide have shown that MSI cancers are often associated with a younger age, an advanced stage, with a mucinous histology, show poor response to 5-fluorouracil-based therapy, but have a favorable outcome with significant survival advantage. So as part of this retrospective study, I retrieved 30 archived tissue samples from young patients with mucinous colorectal cancers to ascertain their MSI status. This was done by a PCR-based capillary electrophoresis technique, as well as by immunohistochemical, or IHC, analysis. For molecular testing, 2 markers were used, and the results were interpreted by gene scan, and for 3 IHC markers were used to determine the MMR protein expression status. What I found was this: 8 out of 30 patients showed MSI by molecular testing, and 7 of these 8 patients also showed absence of mismatch repair protein expression by IHC. This data helped me determine the fact that at least 1/4 of young patients with mucinous colorectal cancers harbor MSI tumors. While this subset of patients have a better prognosis, it also shows us the subset of patients that are unlikely to respond to 5-fluorouracil-based chemotherapy. Therefore, the study not only helped us to validate the molecular and immunohistochemical markers as panels for MSI testing, but also helped to provide a predictive tool to the clinician. MSI testing is now made available as part of our routine diagnostics in CMC. Thank you.
Good morning, I'm Savita. I'm from Department of Hematology and I'm working under supervision of Dr. Pungulli Balasubramanian. Since its discovery in early 1960s, daunorubicin has been used in the treatment of acute leukemias, and it has been standard of care in the treatment of acute myeloid leukemia along with cytarabine. Daunorubicin is chemically an anthracycline and it enters the cell by passive diffusion and brings about cell kill by disrupting normal function of nucleus and mitochondria and ROS generation. Though it is one of the potent compounds known, its activity is not seen, and leukemic cells are able to escape its cell kill, and that is one of the mechanisms of resistance. So my PhD work is to identify mechanism of daunorubicin resistance in acute myeloid leukemia. As daunorubicin is substrate of ATP binding cassette transporters, and also it is metabolized into its less active metabolite daunorubicinol by carbonyl reductase 1 and carbonyl reductase 3. We measured mRNA expression of 14 ABC transporters and carbonyl reductase 1 and 3 by real-time PCR. And we also carried out in vitro cytotoxicity assay of daunorubicin by MTT assay. Based on the inhibitory concentration 50 of daunorubicin, we classified the samples into sensitive, intermediate, and resistant. We also screened the polymorphisms in these genes. Apart from, then we compared the expression of these transporters with IC50, and we could see that there is elevated expression of ABCB6, ABCC3, and CBR1 in resistant samples. This is in vitro. So we then, in a subset of AML patients who underwent treatment in our center, we carried out pharmacokinetic analysis. We measured the levels of daunorubicin and daunorubicinol by both at plasma and intracellular levels by high performance liquid chromatography, and we also we calculated the area under curve and a clearance of both daunorubicin and daunorubicinol. Then we compared the genetic factors with the pharmacokinetic parameters, and we could see that expression as well as the polymorphisms of CBR1 is significantly influencing the pharmacokinetics of both daunorubicin and daunorubicinol. Finally, we checked whether these genetic factors have any influence on the treatment outcome in AML patients. We could see that ABCB1 SNPs are able to influence the treatment outcome, as variants of ABCB1 SNPs had significantly had better event-free survival compared to the patients who had wild type. So my thesis suggests that wide variation in expression in daunorubicin transporters and CBR1 has influence on AML treatment. Thank you.
Good morning all. I am Ansu Abolex from the Department of Hematology, and I am working under the guidance of Dr. Vikram Matthews. My PhD work mainly evaluates the strategies to potentiate immune response in leukemia, especially in acute promyelocytic leukemia. We as clinicians and researchers always aims for a better treatment of the patients with minimum side effects. Cancer immunosurveillance is a mechanism by which our own body's immune system helps to eliminate the cancer cells. But when cancer cells escape from the immune control, immune evasion occurs, which is a hallmark of cancer pathogenesis. And immunotherapy always works to harness our own innate immune powers of the immune system to eliminate the cancer cells. So here we take acute promyelocytic leukemia as a proof of concept of how immunotherapy works. APML comes under the classification of AML-N3 with T1517 translocation, resulting in PML-RR alpha oncoprotein, resulting in the differentiation arrest at the promyelocyte stage. And the standard of care is all-trans retinoic acid or arsenic trioxide. So in this study, we have established an APML transplantable mouse model, and also we have patients diagnosed with APL. So in APL transplantable mouse model, we have a non-specific DNA vaccine which enhances the immune response along with arsenic trioxide or ATRA by the production of anti-RR alpha antibodies, and thus improved the survival in the mice model, as you can see in this Kaplan-Meier curve. So DNA vaccine as an adjuvant to Atra and arsenic can enhance the immune response. It has a potential to translate to clinic, especially for the high-risk patients. So in our patient cohort, we have a very unexpected finding that there is a very low natural killer cell recovery even after the treatment. As you can see from that graph, patient samples were collected at different time points of the therapy and the immune reconstitution was assessed. Compared with all the other subsets, NK cell recovery is very low. But very interestingly, when we treat an APMS cell line NB4 with arsenic trioxide and co-cultured with NK cells has an improved cytotoxic effect when compared with untreated cells, and it is very significant. Since NK cells are very crucial for anti-leukemic effect, we can enhance NK cell recovery in those patients by giving NK cell infusions or cell therapy or by cytokine therapy. So this giving of NK cell recovery or cell infusions also has a potential to translate to clinic, especially for high-risk patients. So our study suggests that use of DNA vaccine, production of antibodies and the NK cell infusions could enhance the immune response and can potentially improve the clinical outcomes, especially in case of high-risk patients. Thank you.
Very good morning to one and all present here. Myself Harish Kumar. I am from Department of Bioengineering, Christian Medical College. My thesis topic is on affordable digital hearing aid with inbuilt audiometer under the guidance of Dr. Suresh Devasaham from the Department of Bioengineering under the co-guidance of Dr. Raju Michael from the Department of ENT, Unit 1. So globally, 360 million population are suffering from the hearing loss, and in India, more than 5 million people are having hearing loss. But the problem is they don't have a affordable hearing aid with them. On the other hand, rural population in and around the Vellore, they often ignore their hearing loss and they often hesitate to come and visit the hearing loss, to the ENT especially. The reason being they don't have a affordable hearing aid. So WHO guideline says that an affordable hearing aid should be of less than 3% of country's gross national income. But in India, it should be around 2,820 rupees. So based on this, my thesis objective was to design a low-cost digital hearing aid with inbuilt audiometer and to test the efficacy of the device by conducting clinical pilot studies. The inbuilt audiometry helps the rural population. So even a community health worker can go into the community, he can do the audiology test in the community. So this helps the rural population. They need not to come all the way to a hospital for diagnosing the hearing problems. So we have designed a body-worn digital hearing aid with inbuilt audiometry. So I have also developed a graphical user interface which can be reprogrammed in the community. So it is a binaural processing with 4 bands and it has a rechargeable battery also. So we have done a clinical trials. So we designed a digital hearing aid. So we have recruited 5 subjects. We done a interventional pilot study after approval from the Institution Review Board. So children and profound hearing loss, people with profound hearing loss were excluded. As a result, the primary outcome was to check whether they have improved hearing level and improved speech intelligibility. This was measured by conducting a pure tone audiometry and speech audiometry. And the secondary outcome was to whether the device was providing the comfort and ease of use. We measured the secondary outcome by using 3 standard questionnaires. So the result was it benefited the mild to moderately hearing loss. It was not benefiting to moderately severe hearing loss. The reason being we have designed with the acoustic gain of 32 decibels. It was not comfortable to the patients and they felt shy to wear the hearing aid. So to conclude, an affordable hearing aid was developed with a bill of material less than 3,000 rupees. It has a potential to use within a community with the help of community health worker also. So we have some of the limitations. So once we overcome the limitations, we have a plan to make it commercially available in the market. Thank you.
Good morning, everyone. I am Selvin from Department of Medicine. My thesis was on ATT-induced hepatitis. My guides were Dr. Ramya and Dr. Anand. Tuberculosis still remains a major global health problem, which is the second leading cause of death from infectious disease apart from HIV infection. This is this is a statistic, Zacharias. There are 2.7 lakh deaths because of tuberculosis in India in 2012. This is despite the availability of treatment, which will cure most cases of tuberculosis. The four first-line drugs, which are isoniazid, rifampicin, pyrazinamide, are hepatotoxic. Incidence of ATT-induced hepatitis, which ranges from 3 to 28% in different countries. In India, it ranges from 10 to 15%. There are many risk factor studies which help to predict the drug-induced liver injury before initiation of treatment. Despite that, we are still unable to predict drug-induced liver injury before initiation of treatment. This is the aim behind this study. So what we did, we enrolled patients, it's a nested case control study. We enrolled patients from the Department of General Medicine and DOTS clinic in Chad. So it was conducted between 2013 to 14. We enrolled a total of 393 patients who were newly diagnosed of tuberculosis and started on anti-tubercular treatment, and we followed them up till they completed the treatment. So what did we find? So the incidence of ATT-induced hepatitis was 9.7%, which is comparable to the other Indian studies where it ranges from 10 to 15%. But there was a significant difference between the people started on different regimens. Daily regimen, the incidence was 14%, and it was 3.5% in DOTS regimen. But we still need more studies to conclude before favoring a DOTS regimen. We still need more studies on follow-up and the incidence of resistant tuberculosis. So these are the clinical risk factors we found. One is HIV infection, disseminated TB, daily regimen, chronic liver disease, female gender, and low albumin, which predisposed them to ATT-induced hepatitis. Okay, and this is a model of impact we can develop. You can model of impact of DILI on TB treatment, which can develop from our study. If 400 patients we start them on anti-tubercular treatment, 40 patients can develop drug-induced liver injury, and 4 of them will develop acute liver failure, and one patient will die. So, how long did it take to develop ATT-induced hepatitis? Most patients develop within the 2 months, that is out of 30 out of 43 patients, and majority developing within first 2 weeks. So what are the statistics on rechallenge hepatitis? So we rechallenged the patients, it was an observational study. What we found out was there is no difference in rechallenge hepatitis between ATS and BTS guidelines. Okay, finally future work, we're planning to do the genetic risk factors which can predict drug-induced liver injury. Also we formulated a predictive scoring which are planning to validate it. One limitation in our study was we are not able to complete the sample size and people are lost to follow up. We are planning to follow them up subsequently through phone. Thank you.
Good morning, I'm Nirmal. I'm coming from Department of Medicine. I did my thesis on organophosphorus poisoning under guidance of Dr. Anand Zakaria. As anyone who would have gone through the Department of Medicine, they would have noticed we have quite a few patients who present with organophosphorus poisoning. Organophosphorus poisoning, the two most common complications which we see is, one is patients develop breathing difficulty and muscular weakness. Other than that, they can develop altered sensorium. The incidence of breathing difficulty is anywhere between 15 to 40%, and which patient will develop breathing difficulty is anybody's guess. So we thought we will go back and we did a little bit of homework and we looked at a study which was done in CMC. We thought we'll build a scoring system which can predict which patient will develop the breathing difficulty. We looked at a retrospective study in which we found out 5 risk factors. We found a predictive scoring system. The predictive scoring system has a minimum score of 5 and a maximum score of 13. We applied it prospectively to patients who presented to emergency department, and we looked at which patient developed the breathing difficulty. We found out that patients who had a score of less than 8 had a very, very, very low chance of developing the breathing difficulty and what we call as intermediate syndrome. So, what does this mean to us? This essentially means that patients who have a low score can be easily managed in the outer corridor, or maybe even can be discharged early if we have enough evidence, if we are satisfied with the scoring system. And in the problem what we are having with the bed crisis, we can actually, if they have a lower score, we can discharge them early, which is good news for at so many levels for doctors who are working in medical wards. The second part of the study was what we call as delayed organophosphorus poisoning, or what we call as a CNS intermediate syndrome. This term is actually very dear to us because this was introduced to the rest of the world by our very own department, and in our hospital. It's actually altered sensorium which develops in patients who presents with organophosphorus poisoning. Almost all the patients, 80% of the patients will develop acute altered sensorium, but there are very few patients. Only 4 out of the 70 patients who are enrolled developed delayed encephalopathy, delayed altered sensorium, which persisted beyond the first 3 days. And we noticed that this was much more rarely seen than the breathing difficulty which patients develop. And what's the mechanism between the altered sensorium is still to be discovered. So what, as we call, the intermediate syndrome is what happens peripherally, and what we call, what happens in the central nervous system is we call as a CNS intermediate syndrome, or the delayed organophosphorus encephalopathy. Future directions for the study is to look for mechanism for what may cause the altered sensorium, as well as our predictive scoring system to be applied as a day-to-day basis with organophosphorus poisoning.
I'm Dr. Jayasheela from Department of Obstetrics and Gynecology. I did my thesis prevalence of genitourinary symptoms, prevalence of metabolic syndrome, and correlation of genitourinary symptoms among postmenopausal women attending our OPD. Here, menopause, almost 1/3 of the women spend after postmenopausal period. Here you see the picture, 7 dwarfs of menopause: itchy, bitchy, sweaty, sleepy, bloated, forgetful, and psychopath. Obviously, along to the 7 dwarfs, one more is getting added. This is what our research question is. Every other grandma in our house is polypharmacy. Is it worth? What is the quality of life for them? 1 in 3 women are suffering from metabolic syndrome. And prevalence study shows almost 18 to 60% of women are suffering from metabolic syndrome after postmenopausal period. What is metabolic syndrome then? It's a chaos, lot of definitions, lot of criterias. Where is the end point? We used International Diabetes Federation criteria to diagnose metabolic syndrome. Our prevalence is 60%. Menopause rating scale and Bristol female lower urinary tract symptoms was used to diagnose the menopausal symptoms and lower urinary tract symptoms among our postmenopausal women attending our OPD. It was a cross-sectional study done in our department for the past 1 year who are attending our menopause clinic. We found it's an alarming call and wake-up call for all of us to be aware of this dreadful morbid causing and mortality-inducing cardiovascular morbidity, and create an awareness to change their lifestyle. Otherwise, one more dwarf is adding on to the menopause. To improve the quality of life, I suggest we have to create an awareness among them to go into annual medical checkups and change their lifestyle to improve the quality of life. Thank you all for giving me this opportunity.
Competitors, now we'll just have a few minutes for the marks to be tallied. Before that, I'd like to ask all the judges if they have any comments, or just like to give any feedback for the participants.
I think every participant did a fantastic job of presenting their work in 3 minutes, and a big round of applause, I think, for all the participants. I'm really proud to be in CMC to see such good work and the diversity of work that has been presented. So I think, we are really privileged to be in this institution where such good work is being done by our junior faculty. So I'd like to just commend every one of you who participated, and wish you all the very best. One suggestion that, whether it's very difficult for us judges to, discriminate, but maybe we should have separate categories, basic science and clinical.
I echo Dr. Pirikail's comments. It is mind-blowing, the spectrum of work and the topics. Just one small suggestion, try to follow the rigors of scientific logic of how you present. What was the aim? How did you go about in your methodology? What statistical tools you use? I know it's only 3 minutes, but many could present a little bit of detail on what they did. Even the sample size for some studies we weren't sure. So just that suggestion alone. Well done.
First of all, I would like to congratulate all the presenters. It was really exciting to see such kind of presentation actually with a short time. And everybody has done, in a very exceptional manner, but it's very difficult to judge also for this. And one thing is actually, as JVP said, but if you just follow actually the logic of sequence and all the aspects if you cover, actually it would be nice actually for everyone to judge completely what you have done actually in order of sequence. But many of you actually just miss the methodology and other things. But it would be useful if you just cover all the aspects within the 3 minutes, and it would be more useful actually even for the judges also to look at actually in a more intensive manner. Thank you.
Well, the judges deliberate. The judges need just a minute to finalize their decision. Ibrahim to give away the prizes. We'll start with the third, second, and then the first. I hope so. All the participants are here. I think some of them are at the OPD. The third prize goes to Harish Kumar from Bioengineering. Second prize goes to Anand R from Biochemistry. Joshua, you are the first prize winner. Congratulations, Joshua. Well done, Joshua.
No, I was just telling Joshua that it is very difficult for a surgeon to do a randomized control trial, and I think he's done a very creditable job. And I think his presentation also is very good. He followed the rigors of a well-conducted study, so all the very best.
Thank you all for coming, and I hope you had a good morning. See you next year again. Thank you.